Hello, everyone. My name is Jose Hernandez with United Spinal Association.
Sorry, I had to find a mute. I'm Jessica with BCID. Hello.
And I'm doing the same thing with my phone and muting it. Are going to go over a few housekeeping rules.
Yes. So if you guys have any questions, you can go ahead and put them in the Q&A section. It helps us keep track with your actual direct questions, but you can go ahead and chat amongst yourselves in the chat box. Also, we're in panelist view, so we can't see you, but you can see us. If you only want to see our ASL interpreter, Vladimir, you can go ahead, right click and pin him.
Also, we have closed captionings available by clicking on the closed captioning button. They are being provided by live transcription, which is Otter AI. And if you want to see the full transcription, you can click on the link that's in the chat. Today, we have Dr. Escalon from Mount Sinai, who is going to tell us about accessing health and in this new world of COVID. So please, Dr. Escalon, introduce yourself and let's start this conversation.
All right, thanks for inviting me. So my name is Miguel Escalon. I'm a rehab doctor at Mount Sinai. So while I mostly specialize in people that have had some kind of neurological injury, spinal cord injury or brain injury of any kind, I see all kinds of patients, mostly people with some kind of functional issue. And so what we wanted to talk about today was just said, which is, how we kind of navigate, or what does maybe healthcare look like in the immediate future. We call the world post-COVID, but I guess we're not really there yet.
Not quite. And what are some of the challenges that you have seen, with the telehealth, since the beginning, like immediately after the shutdown and stuff like that?
Yeah.
And let's go through some of the changes and some of the advantages and disadvantages.
Yeah. So telehealth has been around a while, but nobody really used it. I think we as doctors always thought patients would rather be seen in person. So when COVID hit, telehealth, or kind of doing a video visit, kind of exactly how we're doing this webinar, became a necessity for people to be seen, because all the clinics closed down. They weren't letting people in. And so actually it was very interesting. At first, the government loosened a lot of guidelines. So usually when we have a video visit, we have to have an encrypted web conference so nobody can sneak in and steal your data or hear you. But it was kind of like the wild, wild west, kind of like in March and April of last year. I could FaceTime people, we could Skype, we could use anything. And so at first it was this bad frenzy. It's like all these people we haven't gotten to see. I don't even know if, Bill and Joe are alive, because I haven't heard from them. I don't know what's going on. So we're just trying to track people down, get them on the phone. And that's how it was at first. I think that it was certainly difficult, and there's an adjustment both from the doctor on how do you run a video visit? How do I examine someone? What are the right questions to ask? Because I can't see you. Sometimes I see you, the way you're moving or the way you're sitting, I feel something is off, and I can ask about that. Over video, that's difficult. So that adjustment from the doctor has to happen, which takes a little time. And I think the same is true for the patient. You have to it takes a little more preparation maybe, because you have to have your list of things. There's no kind of examination of your body to kind of help trigger, oh yeah, they pushed on my stomach and it's sore, so that reminds me I've been having reflux or whatever. But so you have to have your list of things, and if you leave something off, that person hangs up and you're done until whenever else.
Yeah. What was I gonna say? I was gonna ask a question. And I forgot. I had one of those moments. But yeah, I know that on the telehealth visits that I've had, you're right. You can't tell. I mean, usually when you go in person, you have a checklist on what you want to check, what you want to examine. Like, even if the person came in with what they wanted to check, you come in, okay, let's do, like you mentioned earlier, strength tests, let's check your spasticity, if you have a suprapubic tube or whatever the case, let's check the site. Let's go through those, common checks, to make sure that those things are still in proper and working order. But have you developed a type of checklist now with the whole, virtual thing?
You try to, it's hard because it depends on the person. Sometimes, I have people with tetraplegia, not good fine motor, let's say, they have the phone set up. They may not, maybe their home attendant isn't around. So the phone is set up, I can't say, pick up the phone and show me a suprapubic tube site. So it can be difficult. So in some cases, there's nothing that can be done. So if you have the ability, I would say two things. One, have someone there with you if you need help either maneuvering yourself or the phone or whatever you're using. And two, don't be shy. So if a doctor's just asking you questions and they go to hang up, you say, hey, don't you want to watch me, try to walk? Or don't you want to take a look at the wound? Like, I can turn and we can, I can show it to you. So there might be like a little more advocating for yourself because for whatever reason, maybe the doctor makes an assumption you're not going to be able to maneuver the phone.
And since the beginning of the pandemic, have you seen a drop off or people delaying their care because of the whole pandemic? Whether it be not comfortable going to a regular visit or not having the means of actually having a virtual visit.
Yeah. Yes. So I know I have a few patients that don't have phones. I'm sure there are patients that, and you don't have a phone and you may not have internet or a way to do a video call. And so let's say I didn't have in-person visits, what's that person going to do? So that's one thing, a lot of doctors are saying this is great, it's going to increase access, but at the same time, it can still alienate certain people if you're trying to do everything over video or telephone call, and there might be people that don't have that or can't do it. So that's one thing. But in terms of like in-person visits, especially for things like physical therapy and occupational therapy, if I tell a patient they need to come in to see me, they never say no. But for physical therapy and stuff, they say, oh, let's wait. I'm not comfortable yet. I'm still worried about COVID. And it's hard to argue because while a lot of people are getting vaccinated, not everyone has. One of the best things that a patient could do is get vaccinated. So, it doesn't mean that you won't get COVID, but as far as I know, nobody that's been vaccinated with, the Johnson & Johnson or the Pfizer or Moderna has been hospitalized. So some of them have gotten COVID, but nobody's gotten so sick they've had to go to the hospital. So I feel like I got a little off track there. But yeah, I mean, I've also had patients, not so much recently, but especially at first, tell their home attendants and home care not to come. And so that's really a catch-22. If you can't trust your home attendant to like wear their mask or whatever you're worried about, is it worse to let them in or is it worse to not get the care that they provide you? And that's a really hard spot. So that's gotten thankfully better. I haven't heard anyone tell me that in the last 6 months or so, but at first that was a big thing.
I'm going to share a personal story, and since the beginning of the pandemic, it still affects me to this very day. Almost a year ago, about 11 months ago, I lost my personal care attendant to COVID-19, and I had seen him on the Friday where he went home, and he called me on Sunday, says, I'm not feeling well. 2 weeks after that phone call, he passed away. So I understand why some individuals, with disabilities or pre-existing conditions decided to go home care, because you have someone coming into your home. You can be responsible for yourself. You can't be responsible for someone that enters or exits your home. It is a scary thing. Yeah. And then that was me going off, sidetrack. But back to the telehealth. We have one question. Let's go addressing them um as we continue, as we go on. It says, for various good reasons during the pandemic, disabled folks have been fearful of seeking care in person. Have you had any recommended, or have you had to recommend an in-person visit to someone to receive any pushback? I have received any pushback.
Yeah, I mean, I think I've been lucky in that I haven't had any patient tell me no. So we offer, I think we, if you call to schedule an appointment, you could ask, do you want to come in person or video? So we'll never force you to come in person to start. But if we do a video visit and something is happening, we'll talk in that moment. I'll say, I can't really, we could maybe try this if you want to just try and see, but if you really want me to figure out what's going on with you and help you, I have to see you in person. And so I pose it that way. I never I don't I kind of put it in the other person's hands and say, okay, well, I can't help you unless you see me, and then it's kind of up to you. And so I've not had anyone though at that point say, no, I don't want to see you. Um, but I don't know if people would respond differently if I just said, you have to see me, and kind of was very strict about it. I haven't done that, and I haven't had to. Um, so I hope that answers the question. But I think, if a doctor's telling you to come in and you don't feel comfortable, if you don't feel comfortable coming in, and you think that it could maybe be resolved over video, you can ask, hey, is there anything we can try? At least try it at home, and then if that doesn't help, can I come in? Or if the reason you're not sure you want to come in because you don't understand why, maybe like, I don't understand why coming in is going to help. Maybe ask the doctor, like, what is it that you're going to do in person that you can't do over video? And that might help you understand why it would benefit you to come in. Hopefully
Hmm.
they have a good reason. They don't just want to bill you twice.
Yep. So now back to like where we were. What were some of the challenges, like, at the beginning, like,
Yeah.
infrastructure wise?
Yeah. I mean, I think it varied a little bit from hospital to hospital. So I'll speak about Mount Sinai, a little bit about the hospital, and then a little bit about, and then a lot more about outpatient. But gosh, when did New York go on pause? That was like March 16th? No, March 23rd or something like that. New York went on pause and that's whenever nobody could go outside. So at that point, um, really outpatient was open up until that point. And really the hospital was kind of functioning normally until that point. At that point, our inpatient rehab units completely closed. And so all those people that were in the hospital in that moment, we had to send them home, and with very imperfect plans. But, from the hospital's perspective, there was no choice. I mean, I probably remember the news. There were beds in Central Park. We had beds in the hallways. We had beds in the lobby. We had beds in the cafeteria. We had beds in the therapy gyms. There were beds everywhere. So there was no space that could be spared for a patient that didn't have COVID. And so that was the hospital. For outpatient, there was no outpatient visit that was not, it had to be life-threatening. And so I'll give you an example of something that wasn't even considered life-threatening. There were people that had very advanced cancers, and they had surgery scheduled to get them out. And the hospital said that is not immediately life-threatening. You have to go to like New Jersey or some other place to get that surgery done. So they really were only taking people that were like actively having a heart attack, actively having a stroke, dying in that moment. Otherwise, the care was delayed. And I don't know what the hospital would say in hindsight. Those were the decisions that were taken then. So that's what we were dealing with. Um, a few weeks after New York went on pause, we were able to convince the hospital that, and they were on board about it. I think once everyone, things happen so fast, you're trying to like learn to juggle, with knives as you're doing it. So they agreed that pain was something that was emergent enough to warrant a visit. And so we were able to start seeing patients that needed like pain injections and stuff in person, but anything else had to be video. And because we weren't quite ready, there were a few weeks there when New York went on pause, like maybe a couple of weeks where the video system wasn't even set up, it wasn't even ready the way we needed it. So I wouldn't say it was till like April before we really could see it, patients that needed over video.
How did you reach out to patients and let them know that this was available?
Yeah, it's
Is
hard.
that
I think one thing that I didn't necessarily do this personally, but one thing I asked my office to do was find a list of everyone that had, say, like a baclofen pump, or, because you can't let that, you can't just let that run out. It's very dangerous. Or say that was getting pain injections, or say was particularly high risk. Like I said, find everyone that has, tetraplegia and just call all these people, check on them and let them know that we have these visits. I think we posted a little video on the website to let people know that we had the visits. We tweeted about it and stuff. And so I think there was some social media that was tried, but I hope it never happens again. I think there were a lot of things we could have done better, probably in all aspects of society, if it happens again. But I don't think any of us were prepared those first couple days.
I don't think anyone expected a global pandemic to happen. Well, some people would have said that this was inevitable, but we definitely weren't prepared for it at this current moment. And hopefully we take this as a lesson and bolster our infrastructures to make sure that, we are ready for something like this if it happens again in the future. I'm gonna just take a few questions. So we have another one that says, have you encountered any unusual billing issues for services you've provided during the pandemic?
Yeah, I mean, it's a fair question. I kind of threw a joke in there, but I haven't encountered any unusual billing issues from my end. I think at first, this is something interesting you should know about. I don't know why I didn't think about it before, but up until very recently, and maybe it hasn't changed yet, maybe it's like next month, a video visit would pay a doctor the same as an in-person visit. But starting soon, the video visits will pay less than the in-person visits. So I'll be curious to see, what doctors do. I think that there's a role for both. I don't want you to be my patient and I never see you in person, but there's probably a good amount of my patients that I can see over video a good amount of the time, and then every now and then they come in person. So I think that there's a role for video visits, and I don't think that they're going anywhere. Sometimes they're just a necessity. I mean, I have patients that use power chairs or wheelchairs and they live in a walk-up. And, if I don't video visit them, I'm just not going to see them. So I would want to keep them. I'm curious what'll happen to the proportion of video to in-person visits then, but I haven't seen any weird billing or anything. I'm not sure if there's something you've seen on your end as a patient.
Hey, I just wanted to add something real quick about my mom and this whole telehealth stuff. She's been doing like OT and PT now, telehealth wise. So although with the pandemic, it has caused like a lot of chaos and stuff, trying to figure out what works. There's a whole other side of people who were maybe not able to have access to go in person because of transportation or home care or whatever. So it's opened this whole new door to have people, for people to have better access to these types of services. So there is, you know, the good side of it too. My mom is a homebody, so I'm trying to get her to go back out and do actual therapy at the clinic. So let's hope that they tell her one day she can't do no more telehealth, just so she can leave the house and not be so scared. But it's definitely been good. You know, my mom has cerebral palsy, and you know, when you sit still for too long, you know, muscles that already have issues start to get worse. So, yeah. Jose, do you want me to do that? Okay. So Maria says, hi, Dr. Escalon, as a health professional, and with all the previous case scenarios that you just mentioned, have you considered advocating for the many disabled citizens, patients, who have had issues with home attendant services and who have no means to pay for internet or smart gadget? Do you work with Dr. Petuno?
So yes, I
Dr.
work with Dr.
Petrino.
Petrino. Yeah, I work with Dr. Petrino, not every day in the clinic side by side or anything. His role is a bit different. Yeah, I mean, I would love to advocate more. I think one thing that you all could help us with as doctors is we're not the best at knowing how to do that. You know, nobody teaches us in medical school what it means to advocate in the community or do those kinds of things. And for whatever reason, right or wrong, sometimes a letter from a doctor can mean more than a letter from someone else. So, you know, I'm open to doing more. You know, I try to do things like this, and I write letters all the time for people to get, you know, for their electricity bills or whatever like that. Um, but, you know, I'm very open, and I think probably what you'll find is most doctors are willing to help. They just don't know what to do besides, you know, sign the petitions or like send a letter to a congressperson. But I know there's a lot more going on. I don't always know how to go about doing it or getting involved.
Yeah, the pandemic definitely put a spotlight on the digital divide. You know, people who have and people who don't have access to it. So we have another question is, did you see a decline in spinal cord injuries over the past year since people were not going out or traveling as much? Or did the escalating gun violence actually result in an increase of injuries? Are SEI patients currently getting an effective treatment with the restrictions on outpatient services?
Yeah, we had a spike with the gun violence. That thankfully has gone down, but we had a big spike during that time, and our unit was at that time it was reopened, so it was full of people with traumatic spinal cord injuries. Now I think we're probably back to a relatively normal amount, and we're also seeing accidents, you know, skiing accidents or car accidents. So it's clear people are getting outside more. In terms of outpatient, it's hard to say. You know, our outpatient is open, so it just depends if a patient wants to go. At first, they were spreading the appointments out so much that we couldn't take that many people. But I think that we've gotten better about learning how to schedule, and you know, the therapists are all vaccinated and things like that, and so we're fitting a lot more people in than we did at first. So we've kind of learned along the way to do that. But I do think that there was a time last year that when outpatient services closed, and even gyms, you know, if you aren't using PT or OT, but you go to the gym, if you have one, you know, a lot of my patients, probably, I would say 8 or 9 out of 10 patients feel worse functionally now than they did, you know, now than they did this time last year, right before the pandemic, because they just haven't been as active. And I think that certainly would be true for, you know, a decent chunk of people that maybe came through the hospital at a certain time when our outpatient hadn't really figured everything out or wasn't able to accommodate everyone that we wanted.
Yeah. The next series of questions are going to go completely off topic.
Okay.
Wait, but I wanted to do Debbie because I think that's a question that's been driving me crazy. I'm sorry, I'm skipping you, whatever. But Why do you think people with spinal cord injuries were excluded from the priority levels of vaccinations? And it blew my mind because it didn't make sense to me, because I was thinking about Jose, and I'm like, you can't cough up the same way, you know, somebody else can. So if you get sick, it's like a catastrophe, you know, like, and I have OI, as I mentioned earlier, osteogenesis imperfecta. So like, and asthma. So I have a double whammy, you know, like breathing is important. Hello?
Yeah, I think I'm gonna make kind of a silly joke first, and then I'll answer the question seriously. I joked with my wife at first because this came up and I was upset about it. And I said, you know what, we should just vaccinate all those 20-year-olds that are on Miami Beach because they're the ones spreading the thing, and then everyone else can get it. But anyway, I'm not, you know, I think, you know, this is going to be conjecture or me just guessing because I wasn't in those meetings, but I'm sure the people that made these calls made them not understanding some certain diagnoses, and then you know, they just were what they were and they just moved forward. I think that, and it wasn't just spinal cord injury. I've had a lot of patients come through, for example, multiple sclerosis. They weren't considered either. And if you think about it that way, you know, they have also, a lot of them are on medications that bring down their immune system. So you could look just like a person that had a traumatic spinal cord injury, let's say, and have an immune issue and still not qualify. So it was frustrating for pretty much every single one of my patients, unless you happen to be old enough.
And it's something that upset me to no end. And through advocating, I was able to get some vaccines for, you know, members of our community and members for our ICS. You know, there was a carve out, and thankfully, I was able to get my vaccine as well. But we were definitely on that later scale of the, you know, priority list.
Yeah.
You know,
And then by the time that people with those injuries or issues were on the list, like that was when it was so hard to like get an appointment.
Yep, and that's why they prioritized um, the economy, and I will continue to say it. The economy was a lot more important um, than the people who could have actually died from the virus itself. You know, the cab drivers and restaurant workers were prioritized over people with disabilities and pre-existing conditions. So, but that's again another topic of discussion. I'm gonna go on to another question. It's, and I'm gonna put these two questions together from the same person. This is why hospitals are not vaccinating patients. Why some particular settings are. Is it to avoid spread of COVID in hospitals? And the same on the same question is that is the COVID vaccine similar to the flu vaccine to reduce the severe effects if one gets COVID?
Yeah, so the vaccines are a little different. So the Pfizer and the Moderna vaccines are what's called RNA vaccines, which is RNA is similar to DNA. It's a little complicated, but basically they're just parts of the virus. It's not alive or anything. It's just a little part of the virus that your body's immune system would recognize. So then when you come in contact with the virus, your body will be ready to destroy it. The Johnson and Johnson vaccine is a little different. It's kind of like the actual virus, but kind of like in a dead state is one way you could think of it, or like super weakened. And so then your body sees the whole virus and attacks the whole virus. So one vaccine is like just a part of the virus for the two first ones. And then the other vaccine is the whole virus. And but in either case, you know, they're supposed to work the same, and that your body recognizes COVID and then attacks it and kills it. I think the important thing to take away from the viruses, because a lot of people the vaccinations, a lot of people get caught up with the percentages of how much they help. So like the Moderna and Pfizer are 90-something% effective in preventing infection, and Johnson & Johnson is in the 70%. Usually flu vaccines are considered good if they're like 60% or higher. So 70% actually is really excellent. And the most important part, say for Johnson & Johnson and the others, is that even if you got COVID, you wouldn't get very sick. You wouldn't have to go to the hospital. And so that's what's important. We want to keep people from dying. And certainly we would also want to keep the spread from happening as much as possible. But the most important thing, is we want to keep you safe. So any of the vaccines, if I got my vaccine, luckily, but if I hadn't, I would take any of the three. I would just take whatever they had. I wouldn't ask any questions.
No. Got it, Jessica.
No, I was just gonna read Dennis's question. So he says, I'm Dennis from Harlem Independent Living Center. Woo, woo, hello. If a deaf person requests the accommodation for ASL interpreter and to get a vaccine, so any hospital or pharmacy can provide ASL interpreter or video reply interpreter?
So good question. So one really quick thing I forgot to answer on the previous question about hospitals not giving vaccines. I can only, I know Metropolitan was giving a lot of vaccines. I can just speak for Mount Sinai. There was a time that we stopped giving patients vaccines because we ran out. And the allotment that comes through the hospitals, I guess, is only a certain amount. I don't know. It's been frustrating, I think, for a lot of people. So the hospital's kind of handling it. So if you come to me and ask me to get you on the list, I don't have access to the list. So then I have to email someone else. And it's kind of like this weird bureaucracy. It's not like a flu vaccine, which I could just have in the office and give you. But now, today, a hospital should be doing it. Like every day at Mount Sinai, there's this long line of people I see every day. But that wasn't the case like a couple months ago. So I think the hospitals are doing them again now. Now, in terms of your question, Dennis, again, I'm sorry I could only speak for Mount Sinai. I know that we have, if it's a planned visit, we can have an in-person interpreter for you. But I know that we have these little video iPad things that come around. And so we have it for ASL or any language, really. And you click on it, and then you click what you want, and the little interpreter comes up. So that should be doable. I mean, in an ideal world, somebody would know you're coming. So, and have all that ready so you don't have to worry about it. But I know at Mount Sinai, we have that available. It just, by the time you come in and explain to someone, maybe you could have it written out. It might take a little while for them to pull someone over or pull the iPad thing over, but we have it.
Now we have another question that says, did you get any feedback from patients of yours who were trying to get outside for exercise or fresh air about their ability to do so?
Yeah, I mean, most of my patients weren't going outside for a long time. And so I think we talked about this a little bit before, they stopped going to therapy or stopped going to the gym or stopped going outside. Some of my patients that had the means, went to their houses in the Hamptons or, Connecticut or wherever, so they could go outside. But people that lived in the city, people were scared to go outside, and I couldn't blame them, especially before the vaccine was out. What was I going to tell people? Yeah, that's fine. Do the best you can inside. I think you have to be practical. As a doctor, the textbook answer is you got to exercise, you got to get outside. But the answer that makes sense is let's split the difference. Exercise inside, be safe, and we'll deal with it together. So, like most of my patients had an issue getting outside. I think now with it becoming warmer, people being vaccinated, I'm hoping people will be able to get outside and places will open up more. And I'm thankful to all the groups that have put up online classes. That's been really helpful because the other thing is it's hard to know what to do on your own.
Yep, no, definitely. You can go online, go to United Spinal Association website. You can go to the NYC Spinal website and you can find a calendar of events, things that are done across the U.S. Exercise, you got support groups, you have everything. You can find it all online. What was I gonna say? Jessica and I, we were a little adventurous, and we went outside when it during the summer, and you can literally stand in the middle of Times Square on Fifth Avenue and lay in the middle of the street and not get hit by a car. That's how desolate the city was. So it was bad.
Terrifying. It was like the movie I Am Legend.
Yeah. So the following question is, have you had to advocate for inpatients to have their attendants or support person be with them in the hospital?
Yeah, I think this is another one of those things that's very different now than it was at first. You know, at first, they stopped letting visitors in, and that was it. You know, it was the nurses and the nursing aides. Those were the person that helped you, the people that helped you, and that was it. And they weren't letting anybody else in, no matter what. The restrictions are loosened now. So, for example, at Mount Sinai, you can have visitors, for several hours, 4 to 6 hours a day. They have to be screened and checked in. So you could have, say, an attendant or an aide if you wanted to come in for a certain amount of time, but they're still limited hours. So, again, it kind of depends on the situation. So I'm not sure I'm answering your question the way you want it. I mean, we advocate and we tell people what patients need. So if a patient needs to be turned every 2 hours, that happens, and it's supposed to happen. And we should be able to do that as a hospital without relying on people having to bring in extra help. But I know, and maybe other people on this call know, that it's not always perfect that way. So I think one thing that we're working on, especially for persons with certain disabilities, is figuring out a way that we know when any of you are in the hospital. Because right now, you could come in the hospital and leave. And even if you're my patient, I have no idea unless someone calls me or you tell me. And that happened with a patient not too long ago where I was like, I didn't even know. It's not some kind of alert I get or anything. So that's one thing we're working on as a department, is trying to figure that out so that we can anticipate these kinds of needs and let the other doctors know this is what this person will need, and explain how important it is, and be checking to make sure it's getting done. Even if we're not your main doctor because you're admitted with something else, kind of be behind the scenes, making sure those things happen.
I know you were saying that, I know that things have changed when it comes to patients having visitors, but I also want to caution that that's not in all areas of the hospital. There are still areas in the hospital that visitors are not allowed in, like cancer wards, or I tried to visit my uncle when he was in the hospital, and they had restrictions because there were curtains instead of walls between patients. So it's a case by case, make sure you call ahead to the hospital you're visiting and see what their guidelines are.
Yeah, that's a great point, because even now things change. It seems like they change every day.
Mm-hmm. So, Jessica?
Yeah. The next question says, do you have any information for specific of hospital or pharmacy has available device for ASL interpreters for deaf communities?
Dennis, I think I answered it as best I could. I will look into it, and maybe I can find a way that we can communicate this out through later. But I know that Mount Sinai has that available. I don't know about pharmacies. I would guess like you just go down to the CVS. I would think that probably they don't have it, but I'm not sure. That would just be my totally a guess. Most hospitals are going to have interpreters. It's just a matter of whether or not you're able to get a hold of someone in that hospital so that it's organized, or if you're just going to show up and you're going to wait a while they find someone or find the connection. But hospitals in the city basically have access to interpreters for every language on earth, because we see people that speak every language.
It's just kind of crazy though, you know, like to see that ASL isn't like the normal though. Like it's not just there, it has to be looked for. Like yesterday I went to the clinic and an Asian woman came in and they had a Asian speaking, you know, interpreter, and she got squared away right away. It should just be the normal. I hope we get to a place where it's like that.
I think it's hard too, and this is like sorry, I didn't mean to cut you off. Like it's a social issue, you know. It's not. There are people even that aren't official interpreters. Like say, a lot of people in the hospital speak Spanish, so you know, it should be fine if you don't speak English. But you know, I don't know the numbers on it, but my guess is that probably people with any kind of disability are being hired less than those without. And so that's also part of the problem. It's not like we can be like, oh, hey, I know Johnny that works down the hall, you know, speaks X language. And so we'll just go grab him, you know.
Yep. I know that we've been all over. We've touched on a bunch of different topics, and all of them important. So let me ask this general question, and it's about telehealth. What do you know now that you wish you knew at the beginning of the pandemic about telehealth and virtual visits?
Yeah, that's a good question. I think I wish I knew better at the beginning how to drive the visit. I think that there's an instinct, at least there was for me, to be more passive over video. It's almost like, hey, you're calling me, what do you want? As opposed to, okay, you're in the office, it's my job to get up, to look at you, to find things, and maybe things you're not even thinking about. Like, hey, do you remember, did you get your ultrasound or whatever that maybe you've lost track of? At the beginning, I was like, all right, you're calling me, what's wrong? What's up? Everything's fine, I'll see you later. And so I wish that, and so that's changed for me. Still not the same as in person, but I wish I had been better at that at the beginning. And I think just understanding also how much time video visits took, because I think at first they're always going to take less than in person, even if you kind of go through the same questions. We booked people like very separated because we weren't sure how long they would take. But you know, so we could have maybe seen more people at first than we did because of the way we booked, not understanding how long the video visits would take. And so I hope that didn't delay too much of anything. And the other thing is, that's kind of along those lines, the nice thing about video visits is I can do them whenever. You know, right now, say after this, I got a random 20 minutes. That doesn't give me enough time to walk to the clinic, see you, and come back. But I could do a video visit. So say you call me, you need something, okay, I'll add you on. We got it. And so the convenience and taking advantage of it, as opposed to scheduling it in the traditional way, where set hours and that's it, is also something I think that we're better at now that we weren't at the beginning.
I'm gonna.
I was just gonna say, I'm curious to know, do you feel like over-connected since you see people telehealth and you see people in person? Like me, I'm kind of like, I'm over all this Zoom stuff now, you know?
It's hard. I mean, I think nowadays for any of us, whether it's work or like life, you can't turn it off. You know, your phone dings, you're going to look at it. You know, sometimes it's a patient of mine, sometimes it's my wife, sometimes it's something else. And that's what it is, you know? So people either have my email or they have my chart. You know, I'm answering things all the time, and it just kind of is what it is. You know, there's not this separation. Do I wish sometimes like I could go on vacation and it was vacation? Of course, but I don't think anyone has that anymore. You know, you're always on.
You're always inclined to peek over and like.
Yeah, well, people say, I know he's on vacation, I'll just send him this email, he'll read it when he gets back. You know, it's there. It's not like I don't have my phone.
Yeah. We have another question, but I wanted to say that, you know, I think one of the advantages of the telehealth visits is that people who would have normally not seeked out care because of whatever, like you said, they live in an inaccessible apartment, or they don't want to do the 2-hour ride to have a 30-minute visit. Now they can, pull up their phone, make it a visit for a specific time and get that visit and get that care. So I think that's something that's been great. And even the support services have expanded or seen an explosion of people, who are looking for those virtual visits, virtual support groups. And so one of the advantages of, doing things virtual. But we have another question is, what has been the biggest challenge during the COVID chapter?
Oh my goodness, that's a loaded question. I guess I'll just say from a rehab medicine doctor perspective, finding new ways to deliver care. I think as a field between consumers, meaning people with injuries, therapists and doctors, we've gotten creative in finding ways to get things done. But we've never had to get as creative as we've had to this last year. And one of the things that's been beyond that, one of the things that's been most frustrating is not having as many rehab beds as we normally do. When someone's outpatient, I can figure things out. It's video versus in person. You can, a guy, you figure stuff out. But when a person with a brand new spinal cord injury has to wait 2 extra weeks to get to you because there's a wait list, or they get sent to a subacute rehab because that other hospital doesn't want to wait, that sucks. But there's nothing that we can do about how many beds we have. That's a decision made based on how many COVID patients there are in the hospital and how many beds have to remain open all the time because of the governor's orders and all this stuff. So that's been the hardest thing for me, is just wondering how many people could have come through our inpatient rehab unit that didn't.
We have a statement, not a question. It says, some within the deaf community stopped trying to get an appointment with their doctors because of the lack of communication access. When the shutdown first started, we could not get appointments with interpreters. And then many, including myself, this is Christine Curry, didn't know who was actually seeing patients outside of the hospital. I am a patient of Mount Sinai. I did not know who had virtual appointments and when they were ready to see patients face to face.
Yeah, I mean,
It goes back to the communication.
It's hard. Your doctors or the hospital has to be proactive. And so part of the biggest problem in the pandemic was everything was reactive, because especially at the beginning, it was happening so fast. The more time that passes, the less excuses anyone has, because this has been a year. How you haven't, we've talked about this a few times with ASL interpreters. In a year, nobody's thought about doing this stuff. Maybe the first month or two, okay, but it's been a year. So I think it's fair to be, to raise a little heck if you want. I think there's nothing wrong with that. So I guess I'll leave it at that.
Jessica?
I'm sorry, I'm very technologically challenged. The fact that I can even drive my chair is a miracle. All right, so do you think that the challenges of the past year will discourage people from choosing patient-centered careers like healthcare?
I don't know. I think time will tell. I don't know if less people will choose careers in healthcare, and I think nurses have seen the hardest hit. I think one big problem that a lot of hospitals are having is nurses are quitting, they're burning out, and there aren't enough nursing schools to kind of fill those positions. And a lot of times, at least from my perspective as a doctor, I see you in the morning or I see you in the office. As nurses, more in the hospital. See you in the morning for 10 minutes, I go see the other patients, and I go to my clinic. The nurse is dealing with everything else. And with COVID especially, there's a lot more that's fallen on the nurses. And that's the part I'm most worried about, because we've seen it here, even on the rehab unit. Some nurses have quit because it's the stress that they've been under has been immense. And then also the follow behind that would be nursing assistants. You know, doctors are sheltered from a lot of that. You know, if you have COVID, the doctor comes in, he puts on his gown, or she, they listen to you, and they walk out of the room. But when you have a bowel accident, a nursing aide is cleaning you up. There's nothing, it's not like they can walk out of the room. And so there's stress because of the increased work, but there's all this emotional added stress that they might have. And so that took a big toll, I think, on a lot of people, at least in New York. I'm not sure how much about the rest of the country.
Well, I'm going to say that there's some qualified nurses that have disabilities out there, and a lot of them, even before the pandemic, found it difficult to find a position because of their disability. That's more of a statement, not even a question. But I want to say that, yep. So on that topic, why does someone like Andrea Dezell, aka the seated nurse, who worked in the hospital floor but can't get hired full time after? I just said that.
You were just saying that. It's a fair question. I mean, I think it's certainly a fair question. I'm not sure. I don't hire a nurse. I'm not in charge of that. But it's fair. The people, especially now. I mean, there's really no excuse now. Now, nobody has an excuse, because we need every person that we can to help. And so I think it's flagrantly obvious, if we're not hiring someone that's qualified now, that it's, there's some prejudice there.
Yep.
And Andrea, like myself, like I was telling you earlier, we're comfortable in the hospital setting. That's our normal. So, when you live the life like us, but yes, we should start wrapping it up. Josefina.
Yep. I want to say right now, I want to thank our audience. You guys have been awesome. With the questions, very good ones. I want to thank you, Dr. Escalon, for giving us the opportunity to have this conversation. I want to thank Jessica and BCID. And Vladimir, thank you for being our interpreter.
Thank you. Thank you, Vladimir.
Thanks, everyone.
And you're awesome. And every time your phone dings for your wife, you answer it. Take care.
Take it easy.